Good evening, ladies and gentlemen. I'm Dr. Nishant Sharma. Welcome back to another episode of the series of virtual discussions on arthritis in India, our nationwide dialogue. This series is a joint initiative by Voice of Healthcare and Pfizer, where we talk about different spaces of arthritis, its care, its prevalence, its management strategies, treatment options available. We talk about patient education, measures of preventions, and whatnot. Allow me to welcome my expert panelists. We have with us Dr. Praveen Kumar, Managing Director and HOD of Orthopaedics, Medigo Multispeciality Hospital, Tirupati. Good evening, Doctor. Thank you for joining.
Yes.
We have with us Dr. V.V. Satyanarayana, Ethakota, Consultant Orthopedic Surgeon, Aware, Gleneagles Global Hospital, Hyderabad. Good evening, Doctor. Thank you for joining.
Yes, thank you. Thank you.
And we'll be having two more guests, Dr. S.S.V. Ramana, Professor and HOD at GGH and Medical College, Guntur, and Dr. Kothuri Rajashekar Reddy, Trauma and Joint Replacement Surgeon, Rajashekar Multispeciality Hospital, Guntur. We already have Dr. Ramana joining. Good evening, Dr. Ramana. Yes, sir. Thank you for joining.
Good evening, everybody.
Hi, sir. So we'll start the discussion, and the first part of this discussion will revolve around understanding arthritis and the different types of arthritis that there are. So my question will be for Dr. Ramana. Okay, he just went offline. So we'll start with Dr. Satya then. Dr. Satya, over to you. Please educate our audience, set the tone of this conversation about what is arthritis, what are some common signs and symptoms, the different types of arthritis there are. Please.
Yeah, when you speak about arthritis is a broad terminology which says about there is an pain or stiffness around the joint. If you think about arthritis, we can't say simple arthritis because it involves all the joints from major joints like knee, hip to the small joints like metacarpal joints and all. When you briefly tell about what is the classification of arthritis, in India, there are a lot of classifications. In Western countries, there are brief classification. When we speak in India, the classifications were divided into four main types. The main type of arthritis is, one is degenerative arthritis, which we see in old age population, elderly people. And second most common arthritis, which we see is inflammatory arthritis, again, which is broadly divided into seronegative inflammatory arthritis or seropositive inflammatory arthritis. I'll come again to that inflammatory part. And third is arthritis, infective arthritis, which we see with infection part, which secondary to any infection in the body, we can get an infective arthritis. And last and foremost is traumatic arthritis, which we see in secondary to trauma or any sports injuries and all. When it comes to inflammatory arthritis, which I told about second thing, where there is a seropositive and seronegative. When we come to seropositive, which we commonly see in rheumatoid arthritis, the most common is seropositive arthritis and rheumatoid arthritis. Apart from rheumatoid, we see lupus.
Thank you so much for coming first.
Scleroderma, vascular arthritis, and Sjögren's disease. These are a seropositive arthritis. And when it comes to seronegative arthritis, we see in ankylosing spondylitis, psoriatic arthritis, and reactive arthritis, and other inflammatory arthritis, and other inflammatory diseases which are related to seronegative arthritis. The brace classification to know is four types, that is degenerative, inflammatory, traumatic, and infective arthritis. These are the four types of arthritis. The main symptoms of arthritis, if you see, patient with arthritis, any arthritis, the patient first complains of pain. Pain is the major symptom in any part of the joint. When the patient comes with pain, that is the first commonest symptom. And second thing, it comes with swelling. Arthritis definitely lead to swelling. Then the other part is other things which we see patient to patient is movement, restriction of movement, stiffness, redness around the joint. These are the symptoms based on the type of arthritis. And what are the common areas which we commonly see arthritis is degenerative arthritis in India is most commonly seen in knee, and in Western countries we generally see degenerative in hip because of their habitats. And in India, where we see commonly we squat, sit, cross legs, we do all household activities by doing routine Indian toileting and all. So we generally see knee, major joints like knee. When it comes to inflammatory arthritis, we just commonly see in metacarpal joints and wrist joints and other joints. Coming to, these are the basic things about arthritis. I think so. It will be fine to tell briefly because we can go deep into the arthritis. There's a lot of things to discuss.
Thank you, Dr. Satya. Hi, Dr. Ramana. Yeah, please, Dr. Praveen, you raised your hand. Please tell me.
One more type is crystal arthritis, I think, sir.
Yeah, crystallopathies.
Crystallopathy, sir. Gout and chondrocalcinosis.
Yeah, crystallo-induced arthropathies. It comes under a type of inflammatory arthritis where we can. There are a number of arthritis which we can see. But basic, I was telling because we are discussing a lot of arthritis and all. I think so. Gout also we commonly see, and crystallopathies also, spondylopathies also we see. But basic to remember easily to for the audience and all, I divide into 4 types. But there are a lot of classification. There are a lot of things happening about arthritis and all. Yesterday we had celebrated World Arthritis Day. So a lot of things about arthritis.
Right, sir. Thank you, Dr. Praveen, for adding to that answer. Dr. Ramana, my next question will be for you. Let's talk about early diagnosis. Let's talk about the importance and the impact that early diagnosis has in the overall treatment outcome for individuals with arthritis. Dr. Ramana, are you able to hear us? Yes, sir. Yeah, Dr. Ramana, you can speak, please.
Yeah.
Hi,
So,
good evening. Good evening. Please.
good evening. So the topic is whole arthritis, See, hello?
Yes, please continue,
Hello?
sir.
Yeah.
Yes, sir.
Yeah. So I have seen that the Satya is speaking about the gist of the whole of the arthritis that we come across. So degenerative arthritis, as he said rightly, in the hip joint, in the Western society, in India, usually we come across degenerative arthritis of the knee joint. So many arthritis, as you pretty well know by this time. So inflammatory, infective, so many, but the degenerative very common because nowadays the aging population is growing in India and everywhere. So because of this situation, we are coming across so many degenerative arthritis, especially the knee joint, wherein you can as well conduct knee clinics in every hospital. Thereby, we can diagnose it at the earliest because joint saving is our important motto as an orthopedic surgeon. So wherever that is really possible, we will pick up the diagnosis at the earliest. Thereby, we can save the joints. Thereby, we can prevent them going in for the total knee replacement. That's what I do in generally in our either in the government hospital or in the private hospital. What we do is we always try to pick up the patient at the earliest, 45 to 50 years if they really come. We will try to educate them to abstain from all the nonsense habits like food habits, that is food fats. Always they will have a lot of food fats which they go on taking only one type of food without taking the balanced diet, and also taking the packaged foods, and also taking a lot of this masala and junk foods. All these things we usually ask them to abstain from, and also the colored drinks like Pepsi, Coca-Cola, likewise. All these things will, and also the pan para gutka, these things and these are the important things which we come across, especially in the government hospital. That they will develop a lot of free radicals because of these bad food habits. And the other one is bad habits, as you pretty well know, smoking, alcoholism, this pan para gutka, all these things. And the other one is sedentary life, becoming obese, and stress. Nowadays, stress is totally related to all the cervical spondylosis and also the degenerative arthritis, especially the knee joints. So definitely we are, so whenever a patient of this sort comes 45 to 50 years, we'll try to pick up all these important issues which will really, that means a lifestyle modification, if they really adopt along with our medications, physiotherapy, degenerative arthritis, where when we diagnose it as degenerative, we'll always give them regenerative medicines depending on the situation. So this is what we do. So suppose obesity, let them get reduced in certain sort of weight. It's not that possible all the time, but let them take care of this part. So all the, and also diet, occupationally, if they're continuously sitting on the floor because of their occupation, or climbing the staircases. Suppose Mota Mestri climbs with a lot of weight on his back 4, 5 staircases we observe in Guntur. So these things we will try to educate them. So as they advance in age, better always they modify their lifestyle. Thereby, their degeneration will not will be hastened, and also they have to follow this first step, risk factors avoidance and the lifestyle modification, followed by this sort of adoption of this stress relief methods, the yoga, meditation, such things. This is how
Thank you,
we.
Dr. Ramana, for
Thank you.
very, very nicely summing up and setting the tone
Yeah.
of this discussion. My next question will be for Dr. Praveen. In continuation to what Dr. Ramana was just talking about, let's talk about the management strategies that clinicians deploy. Let's talk about the different medical, different pharmaceutical, surgical options available, and then the lifestyle modifications. I think we'll continue to discuss that throughout the conversation. So please start, Dr. Praveen. Yeah.
Sir, first of all, the cause of arthritis needs to be evaluated. Main cause. In the recent times, I'm observing that concrete jungles, like city lifestyle, everyone will be lying in the second floor, third floor, continuously coming up and down. This is a major cause of arthritis. I feel so in my practice. I'm just putting up a data, like all the patients coming, I'm pulling up a data how which floor they are living in. I pulled up in and around 1800 patients. In that 1800 patients, max number of patients who developed arthritis in and around 35 to 45 years age, they are living in third floor or fourth floor. So I'm just pulling up a data of that thing, and I'm advising them to shift to ground floor, and so many felt comfortable following that. And recently, one more cause, the most neglected thing is hip arthritis, sir. Everyone, as a surgeons, we feel that hip arthritis, no other option other than going for total hip replacement at the age. Like I'm seeing patients are in and around 30, 35 years going for hip replacement post arthritis following avascular necrosis of hip in post-COVID era. But recent strategies, I tried gelineranic acid injections into the weight bearing areas, uh, and bone marrow aspiration cytology in the weight bearing areas. But in the recent 1 year time, I felt that core decompression followed by BMAC infusion are giving best results. They are preventing the collapse of the head and arthritis of the head. And hip arthritis, one most missed parties will always go for joint replacement, sir. But hip can be preserved. Hip preservation
Preserved.
surgery into limelight recent days. I'm not a hip conserving surgeon. I'm sending it to the person who is preserving the hips. They are doing osteotomies and changing the direction, weight bearing area from the damaged part to non-damaged part, and I think they are giving good results, sir. We have to give a light into it. This thing diagnosis part, we will go into routine X-rays. If at all needed, full length weight bearing X-rays are helpful to rule out whether the pathology is in the hip or knee, followed by blood markers, and will be treated accordingly, like osteotomies or recent days PRP is coming into role in 30 to 50 years age. PRPs are being followed, and my experience with PRP is almost like 20 to 30% are only getting benefited from PRP. The two, if they are in stage 2 or in a starting stage of stage 3, sir. Post stage 3 and stage 4, PRP is not so much useful in them. We tried a lot of patients, but not so much useful. But osteotomies are helping in the patients who are having deformities in the knee, like varus and valgus things. These things I like to put into points, sir.
Thank you.
If you
Thank you,
talk
Dr.
about
Praveen.
this third floor and fourth floor living is very dangerous, sir. I'm just pulling up the data. We'll be submit this data in next coming meetings.
Thank you, Dr. Praveen. My next question will be for Dr. Satya. So could you elaborate on the importance of the multidisciplinary approach in managing arthritis, as we see that it is a collaboration between rheumatologists, orthopedic surgeons, spine surgeons, occupational therapists. How do you feel that this approach benefits the patient at a whole?
See, holistic approach to say about arthritis is not an single involvement, because arthritis is generally, if you see about degenerative arthritis, we definitely involve physiotherapists. It is generally seen in an old age population, where we definitely need a family physician, where we can need a psychiatrist. Suppose if you take an holistic approach, we at the global, we have a team of doctors. When we take a patient for an TKR and all, before doing a surgery, we take a 3-4 consultation for the patient to go for a surgery before selecting the patient for osteoarthritis, for any surgery and all. The number one is orthopedician see the patient. Number two, a patient is seen by a general physician, that is called as clinical physician, who can assist his pain score and all. And number three is pain management therapist or anesthetist or critical pain therapist, we call them. They will be having their look. And number four is a physiotherapist. Before taking the patient to surgery, we'll have a pain score or grading score or Q score. And number five is a psychiatrist. Definitely today, multimodal approach to treat any osteoarthritis and or any surgical management and all, we need to have a multimodal approach. We do this, all the teams will have, and we have an patient related outcome measure scores for taking any knee patient to the clinics. We have every clinic, we maintain clinic on every Monday and every Friday, and 2 clinics will be there to see this 5 doctors see the patient. When we select a patient for an arthritis, and when we start treating him in a medical management or surgical management, we ask this all the 5 department to see the patients, and we grade them with them patient related outcome measures. And patients who are getting surgery, we just make sure they follow these 5 people till 6 months. And when you speak about the other departments which involve arthritis, especially rheumatoid arthritis, we need to have a specialist rheumatologist to see these cases. Previously, the orthopedician used to see the cases, but today, we see a lot of inflammatory arthritis after COVID and all. Inflammatory arthritis numbers were increasing a lot, and the role of rheumatologist is very crucial, because this DMRDs or disease modifying drugs, which has a lot of side effects and all, and they need to have a keen observation with medical with a number of lab investigations and all. So definitely we need to have a rheumatologist. And very important thing, any arthritis and all, the doctor's role is 60%, and 20% I say to my patient physiotherapy role, and 20% is the patient's role. So it is not only a doctor's treatment part, it is definitely patient's lifestyle changes and physiotherapist's role, like including braces and all. And very much important is the patient's family support or patient personal support. This all plays crucial roles to treat the patient with arthritis.
Right. Thank you, Dr. Satya. Very nicely summed up answer. Dr. Ramana, my next question will be for you. I hope you can hear us.
Yeah, I'm able to hear you. Yeah.
Yes. Thank you. So as Dr. Satya was just talking about the collaborative approach that we see, and he also mentioned psychologists. Can you shed some light on the psychosocial impact that arthritis has on patients and their families, very precisely, and how can the medical community and the society at large provide a better support for individuals living with arthritis?
Yeah, we have to actually have certain studies actually on this. The problem is we are racing with time, including the doctors, even a daily wage worker also racing with the time. So this is causing a lot of stress, which is leading to production of free radicals, and everywhere there is a degeneration. Right from the cervical spondylosis, I see a lot of patients who comes to us with a lot of stress. So either family stress or the job stress, wherever there is a lot of stress which will produce neck pain, reeling sensation, vertigo, all these things. So likewise knee joint also, I have seen that knee joints are degenerated in people who are having a lot of stress. This may observe it. So we need to change their lifestyle. Psychologists means definitely we have psychiatrists and psychologists everywhere. We need to have the counselings for everywhere. Any disease like nowadays they need some sort of counselings. So this counselling part is also very essential. Apart from the physiotherapist in the orthopedics clinics or orthopedics facilities. So psychology means we need to definitely study on this actually. I think there must be so many studies, especially in the Western world, because every small thing they will try to bring out some studies. But here we don't have such cultures. But we need to have in all the facilities the counselors who will really, the family members also we need to counsel. because to alleviate the stress for a person who has come to you, the whole of the family should be taken care of in a holistic approach. So this is actually very essential. But I don't have. But always I think in terms of the stress. Always, especially when a patient of this sort comes to us, early age patient, not much bad habits, but stress is there. Sedentary life, obesity, these are totally together. And sometimes diabetes, hypertension, all these things put together, this psychological picture is coming into the way. So that is why we need to put together all these things. So psychological stress is causing diabetes, hypertension, obesity, knee joint pains, neck pain. So whatever that is what we need. That's what we need to have the psychologists in the premises and the counselors in the premises, and also the physiotherapists to safeguard their joints by toning up their muscles and all. So the postures also we need to check. See so many young patients when they sit before the computer, they don't know how because of the stress only they sit in the uncomfortable and unaccustomed postures, which will lead to over a period of time, not in a day or two, it will happen. For a period of time, it will happen. It produces, see, you know, chondromalacia patella, theater sign. Suppose young girls also, if they go and sit in the theater for 3 hours, by just pressing the knee and sit for some time, the chondromalacia will happen. So everywhere it can as well be a thing that can as well happen. So all these things, when put into a nutshell, psychological stress also we have to take into the fold of this particular gamut of situations. So that is why this need to be studied actually in Indian circumstances.
Right. Thank you.
That's what
Thank
I
you,
feel.
Dr. Meena, for pointing out such an important topic.
Yeah.
Welcome, Dr. Reddy. Good evening. Thank you for joining. And
Yeah, good
Rajashekar,
evening.
welcome.
Good evening. Thank you, sir. Thank you very much.
yes, sir. So we were discussing with the rest of the panelists, Dr. Reddy, about we have already discussed about the different types of arthritis, the common signs and symptoms, and clinical observations that they see, and we have talked about management. We are now talking about patient education and the awareness that we, through this particular session, are trying to create. My question to you will be that we know arthritis affects a wide range of age groups. No, specifically for the younger population, how do you feel are the lifestyle modifications and the preventive measures that can be implemented so that people can have a reduced risk of developing arthritis?
Yes. Main thing is, see, arthritis can be triggered with lot of factors can trigger the arthritis. So, as we know, we have already discussed the types of arthritis, and mainly the autoimmune system. Once it's triggered, then it can cause this arthritis. So, for this, actually, there are for a few things like food items also can trigger this. Some of the food like pasta, hamburgers, all this fast food nowadays, people, young population are more used to eat fast food nowadays. So for some people, even this milk products like butter or yogurt, this also can trigger. And better is to avoid the triggering factor food, whichever the food is triggering the arthritis. Better to avoid that, and also lifestyle modifications like you should try to avoid the sedentary lifestyle. Try to make yourself move around and do some physical exercises. You should educate patient to mainly do at least if they cannot do strenuous exercises, at least to start with a morning walk or a brisk walk, and to have mobility on day-to-day basis, so that the effect will not be more the joints and all, whatever the arthritic affected joints will not no get worsened, so the symptoms won't get worsened. So, and also there are certain conditions where like for example osteoarthritis of the knee joint, if we consider. So you cannot ask the patient to do the walking, or you cannot ask him to do the regular exercises what other patients can do. So in that case, you can advise them to do cycling or swimming, So depending on the patient to patient, you can advise them to modify the exercise patterns, or their lifestyle modification will definitely have a lot of impact on the outcome of the disease.
Right. Thank you, Dr. Reddy, for that answer. My next question will be for Dr. Praveen. As you had mentioned about PRP and a lot of treatment modalities, any recent advancements or innovative treatments in arthritic management that you have explored and you would like to educate our audience about it, please?
Recently, I am trying BMAX, sir. BMAC is giving good results, but not for definitely not for stage 3 and 4, but in stage 2 and 3 who are in the age of 35 to 45, in and around 50 also it will helping us. And some patients are getting completely pain free, but I think I need to have more pool of patients to be certain about it. But I'm just trying it now, sir. And one more thing, recent days I observed that work from home post COVID era and COVID era, it is causing lot of problems, because in the home they won't be having the office environment. They will be lying on the beds, lying on the floor, playing with the kids and doing the computer work. They will put so much stress on the neck, back, hips, so much thing. So we can even advise to have a office environment in the home, like a office chair and office table, or go to office and work. That will be better for their back, particularly C-spine.
Right. Thank you, Dr. Praveen, for that answer. Dr. Satya, my next question is for you. Now, talking about the section where we address people living with arthritis. So, for a patient living with arthritis, and you would have a lot in your clinical practice, what are some coping strategies that you recommend to individuals? And also tell us about some innovative, your specific innovative techniques that you deploy to manage arthritis for these patients in their daily lives.
See, arthritis, I think so. Managing in day-to-day life is very tough to the patients. See, the arthritis. If a patient an arthritis, we need to see the risk factors why the patient is getting the arthritis. As one of the doctor was describing about the weight, obesity, and all. So, if the patient who is an elderly patient around 60 years, probably developing a knee arthritis, and he's in a grade 3 to grade 4 where he's not requiring surgery, still he need to have a medications and all. The main first important for any arthritis is to lifestyle modification. As the panelists were discussing about the lifestyle modification plays a crucial role for any arthritis. If the patient is obese, try to get cut down his fat or come down the weight. And if patient is who is staying in a second floor or third floor, trying to get down from the stair, so try to shift his to down. Or if a patient is who is doing a day-to-day traveling job, or better to stop the job. Or the small and patient who are regularly squatting or sitting cross legs, kindly advise them to not to do this thing. The first primary very important thing when we are living with arthritis is to change your lifestyle, which is very important for the patient, and to understand the exact root cause of the problem and try to eliminate the cause. And second most common thing is, if the patient want to live with an arthritis, and we need to definitely use a formula, a splint or a brace, which definitely unload the joint and definitely gives the secondary benefits by improving the muscles and all. So if a patient who we advise the patient with a braces. If a patient is having a knee arthritis, based on his grading, we give knee support, we give advanced knee braces. If he's having a medial side wear, we give a medial side varus brace or valgus brace. And there are a lot of advancement braces which will unload the knee joint and definitely will decrease the pain around the knee. And third most important thing is family support. We ask the patient if a wife is suffering, and we'll ask the husband to take care of her, and if a family member, say a daughter or son, to take care of her, and give them some motivative support with pain and all. And fourth most very important thing is, today in Indian scenario, the stick or support, a walker or something, can definitely unload the patient's weight on the knee. And we'll advise the patient who are want to live with arthritis, kindly unload your knee joint pain by taking a small stick, or walk with some of us a kind of a walker or something. And other things which we tell them is a local application of any hot therapy or ice therapy, they can do in the morning and night before going to bed, and put a gel beside their bed, and when they go to bed, try to apply the gel, because night pains are very common in any arthritis, and we do. And the last and most important is counter medication. They can take any paracetamol or brufen tablets or anything. And recently we have some nutricals which has little bit role on moderate to early arthritis. Definitely they helps a lot. And this all together, and patient psychological status, all with all these things, and motivation from the family members and patient himself, can withstand the pain for arthritis. uh, and very very common things which we see in Indian scenario is the people who are with arthritis, they start to get stressed out, and they start to bit worried, because the pain is the most cruciating factor in this arthritis patient. And next is deformating of the knee joints, and socioeconomic status, people who are not ready to do any surgeries and all. So one thing is educate them, educate the family members, and educate the person who is staying with the sufferer. These are the three important things. Whenever you treat in the OPD, I just tell to my patient and patient attenders. The main thing is, you need to counsel them and explain them what level they are there, what stage of arthritis they are there, and what are the treatment options they have, and how much time they can wait for the knee surgeries, or what are the other modalities which they can go, and look about their socioeconomic status, and look about their comorbids, especially comorbid people with have arthritis will have definitely a hypertension or diabetes or thyroid, or any coronary artery disease, or patients will be on anti-epileptics or fibrinotics. So make sure this all things play crucial role, and doing surgery is a last option. But I definitely advise the patient to wait till he need to come and say, sir, I tried all the options, I stayed with arthritis for last 1 year or 2 years or 3 years, still I can't do anything. The only thing is, kindly do a surgery to me. This is the when the patient we can do this. This is the time where we need to take a call and we need to do the surgery.
Right. Thank you, Dr. Satya, for that nicely summed up answer. Dr. Ramana, my next question will be for you.
Yeah,
Uh,
I am
like
ready.
very rightly mentioned by Dr. Satya about a patient from different socio-economic zones might not be able to have the surgery done due to reasons. Now, talking in depth of this, talking about the variation in prevalence that we see in the different socio-economic zones, about the treatment care that we are able to provide in the different socio-economic zones, rural,
Yeah,
urban, difference.
yeah.
We'd like to hear your thoughts on that.
Yeah, actually, I am working as a HOD department of Orthopaedic Guntur Medical College. As you rightly said, we get so many low socioeconomic status patients to our orthopedic OP. So we run orthopedic clinics where we select all the patients who are not having the grade 4 degenerative pathology. So we pick up the patient at the earliest. So at each step we have a treatment modality for them. Supposing early 40 to 45 years, I told you, we will allow the patient to abstain from all the nonsense habits, bad habits and all. Obesity reduction, stress modification, meditation, all these things. This is one part. The other part is, that's what the staircase thing, the sitting on the floor for all the nonsense things. See, females in our women folk in the rural areas, for everything, they happily sit on the floor and do all the work. So we'll just ask them if that's a pleasant thing for them to do, but usually we will ask them to abstain from it. So such things we practice. Later, not now, what we do is we'll examine the patient, the knee joints thoroughly. If I'm just talking about the knee joint arthritis, we'll take the X-ray. Only little degeneration, definitely all these things will be enough. And also to gain the confidence of the patient, we give them little painkillers. Never ever after 50 brufen and all. Only the renal friendly drugs only we give. And this, suppose if they cross this particular point, we'll try to put them on the regenerators. Whatever regenerative medicines that are available with us, we will give the patient the chondroitin sulfate, glucosamine sulfate, hyaluronic acid, MSM, likewise rosehip extracts, whatever that is really, if they can really purchase from outside, we will write prescriptions, or otherwise we have a physiotherapy unit. At this particular point, regeneratives, physiotherapy will try. Usually they will be very, very happy with this treatment. Usually we will try to at least postpone the T-care for 10 years. That will be a great thing what we can do for a low socioeconomic patient. So this is our knee clinics what we do. So lifestyle modification, abstaining from all the things which are coming in the producing early degeneration, bad habits, all these things we take care. Regenerators we give, and the intra-articular hyaluronic acid we have now. That we will try. If there in our OPD also we are giving PRPs. PRPs also we are giving. Platelet rich plasma also we are giving. So up to this, definitely they are with us. They are happily lead their normal lives over a period of time with this. PRP is really helping them out. In the earlier ester years, actually we used to give tricot, triamcinolone acetate, 40 milligrams, 2-3 shots. That was a practice actually. Nowadays we are not giving because we better always keep the joints virgin. If at all, if they can as well go out with the replacement. Better always not to poke anything into the joint. That's what usually we find. We always practice that. I teach my students and all, keep the joint virgin. If they are really able to go for degeneration, I mean this replacement and all, better keep them virgin. So these things we'll try. Suppose if their only medial joint space is narrowed, whole of the other thing, patellofemoral compartment is normal, lateral compartment is normal, then we'll go for high tibial osteotomy. High tibial osteotomy in different with different sorts of fixations. Maybe with a staple, maybe with a tension band wiring, pulled through the lateral collateral ligament, or Ilizero. Likewise, nowadays we can as well go out with the Puddu plate. Also, we are doing it. Now in the Puddu plate, we just open it on the medial side. So usually we do the lateral closed wedge osteotomy, so that we can really open the medial side joint space, and also it will really the mounting pressure inside the proximal tibia because of the venous congestion there, because it is the most important weight bearing joint wherein a lot of venous and arterial plexus is there, genioplexus is there. That plexus we need to decompress because of as the age advances, intraosseous pressure will be more in the proximal tibia. So once we do the osteotomy by taking this particular wedge of the bone after measuring it, what we can do, we are achieving two things. One is decompressing the compartment, thereby reducing the pressure in the intraosseous area. Thereby pain will be drastically reduced, and also we are giving the medial joint space again. So it will be again giving them some life to the particular joint, and they can as well lead another 7 to 10 days. That's what we have a study of 20 patients wherein 7 to 10 years life of the giant was given with this high tibial osteotomy. So many areas. So depending on the patient stage, we will pick up the patient for the different modalities of treatment, and we will try to solace them before they go for total knee replacement. If at all it is totally ruined joint, all the compartments are so many loose bodies, rest pain, all these things put together, definitely we need to go for total knee replacement. But one thing we always stress them: rest is rust. Don't keep. So they will ask. First question they ask is, "Nadiste ma keel aripotaya." We always tell them that they are meant for mobility. So they are meant for mobility. Rest is rust. Better you walk around, but not beyond your limits, pain limits. Of course, we'll alleviate the pain and by these modalities and let them walk happily. This is how we manage different stages of total replacement, different socioeconomic status patients.
Right. Thank
Hello?
you. Thank you, Dr. Ramana, for
Thank
that nicely summed up answer. Moving over, Dr.
Yeah.
Praveen, my next question, as we had started talking about the difference in the healthcare delivery as we see across different socioeconomic zones or maybe demographics, how do you feel can healthcare providers and community work together to improve arthritis at the grassroots level, and any suggestive initiatives that you have, please?
Like we can go into the offices and make them to know the ergonomic seating positions, because a lot of offices won't be following the ergonomic rules, like in which position the height of the table should be, in which position the chair should be. These ergonomics we can educate them so that we can prevent the back pain in the software employees. And regarding the village people, we can go for the health plans with the full team, have a panel of doctors, like as discussed, like general medicine, physiotherapists, go for them, identify at a very early level, and understand them the situation of dealing the problems, like what is the work they have to avoid in order to prevent the arthritis, so that it can be stopped at a early stage. And like this, you have to mingle with the society and educate them, sir. And one more doubt I am having, sir, like actually not a this thing, sir, regarding the kneecaps and all. I feel that sometimes the quadriceps is becoming very weak in the patients who are using a kneecap for a very long time. They are becoming dependent on the braces or kneecaps. Any way to prevent that thing, sir?
See, kneecaps is a very crucial. This is good question. See, there are four different types of kneecaps available in the market. There are four different types. One is knee support, which we give for early arthritis. We should not give any kneecaps for early arthritis. Just we need to give knee support, which gives the comfort to the joint. It is like a socks model. There are two types in that kneecaps, which is a soft model, which is a hard kneecaps. Based on the patient to patient, if their patients are very much, there's an initial pain is swelling, we need to give kneecap. There is second most common is knee immobilizer, or this is called as, which has an two iron splints on either side of the knee, which we can advise for grade 2 to grade 3 arthritis. In this model, the patient, we need to advise knee quadriceps strengthening exercises and kneecap. But the people, whenever we're advising any kneecap or knee support, we need to tell them you need to wear when the patient is mobilizing or when the patient is walking. And the patient should, the kneecaps or knee mobilizers should be removed when they are sitting or when they are sleeping or when lying down position. Many of the patient people comes with, sir, after putting the kneecap, my leg is swollen or my I'm unable to. There are a lot of issues with the knee. The main thing is educating the patient when they are putting that and how to put the kneecaps and when to put the kneecaps is very two things. And there are advanced kneecaps which is called as unloading kneecaps, which are very costly, and definitely the patient who are affordable to buy this unloading knee braces or kneecaps, definitely there are medial unloaders and lateral unloaders. If you see there is a lot of wear in the medial unloading, definitely this medial unloadings will help them. Initially a 2 weeks or 1 week the patient will have a resistance to any kneecap or any knee support under, because anything new to the body definitely there will be resistance, because the patient education is important. And once the patient feels when you apply the kneecap everything will be normal, no, that is not thing. The kneecap is only to support the knee and unload the knee from the knee pains. And one more thing before the previous question regarding the how to improve the community awareness about the knee osteoarthritis. This is very good thing. See, today we have awareness of breast cancer or any malignancies. We have vaccination centers in community health centers. I think so. In Western countries, uh, because the population is less, they have screening centers for arthritis above 45 years. But India, there is a population, huge population in rulers and all. The screening centers we could not keep, because there is the rural doctors, the number of rural doctors to the population is very less. To spread awareness, I think so we need to do multiple camps in every community health center or primary health center, and this should be done by the community healthcare worker or community healthcare officer. And spread awareness about the knee arthritis. Kindly put any hoardings in the community centers. What are the precautions to be taken and how to be done? This can be done. It is a very simple modality but very effective modality. And second thing, giving an ad in a local paper or something, which a community healthcare by government NGOs can be doing this thing. And third thing is mass screening in the population above 50 years, especially in women who are post-menopausal or anything. We need to do a mass screening. Today, osteoarthritis is definitely related to osteoporosis, because patient which there is a cartilage wear and there is a subchondral degeneration also. So osteoporosis patient definitely comes with an arthritis. So screening about osteoporosis is also very important in rural centers. And last and very important thing is awareness among the community should get awareness to spread this awareness. And every whenever they visit the family doctor or something, and the family doctor should know the basic things about the arthritis and all this. If you this thing, we can isolate the arthritis in every, because today every family in India, we need to, there will be an arthritis patient. Either there will be an inflammatory arthritis or there will be an degenerative arthritis, or there will be any other spondyloarthropathies. So today, today's lifestyle modification, we see arthritis in Western population, we see arthritis in urban cities, we see arthritis in rural cities. So we need to live with arthritis. I think arthritis is in future. I think so. Next decade or something, arthritis will become a second or third problem for the country.
Mm-hmm.
It is
Thank
like
you, Dr. Satya. Actually, we'll be closing this session at 7:20. So I'm only left with one last round of questions for everyone. So I'll start with Dr. Reddy. I hope you are able to hear us.
Yes, yes.
Yes, Dr. Reddy. So we had a very lively conversation. We discussed different clinicians, different management strategies, and we understood a lot about arthritis. On this, as we celebrated World Arthritis Day yesterday, on this particular occasion, while we are creating awareness, what is the message that you would like to give to everyone who has engaged with us, be it caregivers, be it patients, be it your colleagues? Yeah.
See, as most of our panelists and doctors have already discussed and highlighted, the first and most important thing is screening and finding out the population who are vulnerable for this osteoarthritis. So screening can be done in community levels with the help of camps or individually at clinic level also. See, for example, in my clinic, I have one panel of investigations where I have named it as arthritic profile. So for any patient who comes with polyarthralgia or wherever we doubt he is having some underlying arthritis, uh, maybe coming with fibromyalgia or coming with osteoarthritis of knee or anything, we do this basic panel of investigations and try to educate the patient at least the basic level where you do the normal regular CBP, ESR, CRP, and then the ASO, RA, uric acid. So the basic profile you do, and then educate them and
Mhm.
try to educate the patient and also teach them some of the preventive measures, and
Right.
also start with if any, for example, if rheumatoid arthritis or something is there, underlying rheumatoid arthritis or PSRA, so start with some DMRDs or as some antibiotic for PSRA. So all
Right.
this we'll do, and then next stage, what we do is we ask the patient to be in follow up, so that
Mhm.
so that we can understand how the patient is coping up with the arthritis, and in
Right.
future if anything is required, for example, especially in osteoarthritis of the knee, already Dr. Ramana sir has very clearly explained about the different stages of osteoarthritis, what are the treatment modalities he is following. So like that, so there sometimes the patient is not affordable. We can even go for certain salvage surgeries. We can even do
Right.
limb salvage, knee, the joint salvage with HTO and all. So all
Mhm.
this we can explain to the patient. We can make them aware of all the present, the latest
Thank
advances
you,
also.
Dr. Reddy, for your very insightful answer. We're moving over, Dr. Praveen, your last one-liner message for everyone who has been a participant to this particular episode.
mobility is life, sir. One liner.
Thank
Mobility
you.
is life.
Uh-huh. Thank you, Dr.
Is
Praveen. Dr. Satya,
rest is rest. Rest is rest. So joints are meant for mobility, and eyes
Yes,
are
yes,
for sight. So these
yes.
they can't be missing this message.
right. With this, thank you, everyone. Any last message that anyone would like to say? One last, please, Dr. Satya.
Yeah, yesterday's Arthritis Day, the 2023, the World Arthritis Day theme is living with rheumatoid and muscular skeletal disease, all the stages of life. This is the theme of the yesterday's arthritis. Last year's theme was joint health for all, but this year theme was this is very brief theme. This is very important theme this year. This living with rheumatoid and musculoskeletal disease in all stages of life. So the important message to the society is keep moving, do low impact activities, eat well, sleep well, don't ignore joint pains, talk to the
Including
specialist, manage your
Yep.
pain. This is mad base.
Okay, with this, I'll bring this panel of discussion to a closure. I would like to thank all the panelists, Dr. Ramana, Dr. Praveen, Dr. Satya, and Dr. Reddy.
Thank you,
for
sir.
spending time out.
Nice.
Thank Pfizer as
Yeah.
well for powering this particular initiative. And have a good evening, gentlemen. Thank you.
Thank you very much.
Take a group photo. Okay, thank you.